Oh, I don't know as many names.
And now we will hear from Starla Blank, who is Pharmacy Clinical Coordinator at St. Peter's in Illinois.
All right.
And Kay is coming to the rescue. Has Kay gotten an appropriate round of applause from this group? She has done a phenomenal job. I could say that from my bed yesterday, even, as I kept track of what was going on down here.
Okay. Well, thank you for the invitation to be here, and I am privileged to be on this panel as well. Though I did think about silently leaving the room a couple of times. So I'm here this morning to tell you about Montana's efforts in implementation of a prescription drug monitoring program. I think from the discussions over the last day or so, you might have some idea of what a prescription monitoring program is, but just to clarify in case that's necessary, it's a program that utilizes a centralized database to collect and analyze controlled substance prescription information that is submitted from pharmacies that dispense prescriptions to residents of that particular state. Then, depending on the program and state, prescribers, dispensers, patients, licensing boards, law enforcement may request information from the prescription monitoring program, and the information will differ again based on the program, but generally includes the names of the prescriptions, the quantity, the prescriber, the method of payment, and the pharmacy where the prescription was filled. The purpose of the PMP, again, varies depending upon the state. PMPs can be a source of information for practitioners and pharmacists to use in the care of their patients. It is also a tool to help deter drug abuse and diversion. It is not intended to prevent patients from obtaining needed drugs or to interfere with legitimate prescribing. Currently, 29 states have PMPs active, and 9 other states have enacted enabling legislation, but their programs are not yet active. This map is, I don't know how effectively you can see that, and this is from 2007, and so it's not completely accurate, but the states in white are those that have made no effort, at least to that date, to enact enabling legislation. Those in yellow, as of 2007, were attempting, and those in blue had enacted legislation but didn't have their program going. Those in the purple color have prescription monitoring programs. Again, for example, Arizona, their legislation was passed, and they would now be blue. And Colorado and North Dakota, for example, have now implemented their program. So it is somewhat of a changing landscape. How could Montana benefit from a prescription monitoring program? By providing timely and accurate access to controlled substance prescription history information. You could confirm compliance with the treatment plan, more early detection of patients receiving prescriptions from multiple providers, multiple pharmacies, and with few addiction treatment resources in Montana, this definitely could benefit Montana. Both national data and Montana data indicates that we do have a prescription drug abuse problem nationwide and in this state. And the scope of the problem, I think, has been laid out in numerous forms through this presentation, so I'm just going to go quite quickly. I'm basing the information that's in my presentation on the substance abuse and mental health services survey that is done every year by SAMHSA. And from 2004, the SAMHSA data indicates that prescription drug abuse is second only to marijuana for drugs of abuse. And this is the most recent data from 2005-2006 surveys that show Montana ranks in the top percent of persons aged 12 or older for illicit use of all drugs. So that includes heroin, cocaine, and non-medical use of prescription drugs. This table did not show up in your handout as I looked at that, so you can see there we are overall. Number 5, our teens are second for overall illicit drug use, and they are third highest percentage in the United States for non-medical use of prescription pain relievers. Also, as part of that SAMHSA study, SAMHSA surveyed those people to ask those children or kids where did they get their drugs of abuse, specifically the pain relievers. And there you can see about 75% from friends, relatives, and doctors. And why? Why are they trending toward prescription drugs? This was a survey done by Partnership for a Drug-Free America in 2005. And the perception is that they're easier to get and they're safer, according to this survey. So again, we've heard a lot at this program about the challenges for prescription monitoring programs. Some programs are better than others. Some groups would like prescription monitoring programs to not be in effect at all. Some would like unfettered access. And again, this forum is a perfect forum for this type of topic because we are looking for a balanced approach. And any effort to reduce prescription drug abuse, as we have learned, must be assessed for the potential impact on patient care. We don't want increased prescriptions for less effective pain medicines. We don't want to scare practitioners away from taking care of legitimate pain needs or limit their prescribing, turning patients away. A lot of the fears come from those prescription monitoring programs where they have only looked at Schedule II drugs. And currently 3 states still do just collect data on prescription Schedule II drugs only. But as you can see, the majority of the states are collecting data on all scheduled drugs of abuse, and some states also have the legislative authority to include non-scheduled drugs of abuse, like Soma or Ultram. A little bit of data on addressing the chilling effect. This is data provided by the Idaho Board of Pharmacy, who does collect all schedules to show that there has been no migration from one schedule to another. Their PMP was implemented in 1997, so this is a fairly robust program that's been going for quite a while. A newer program by the Ohio Board of Pharmacy was implemented in 2005, and this is their most recent data. Again, showing no migration from, major migration from one schedule to the other, proving that it is best for PMP to collect data on all schedules. There are guiding principles for prescription monitoring programs put out by multiple interested parties, and I believe that there is one on the table from the Cancer Action Network, which is part of the American Cancer Society, which I included in my presentation and didn't know they were going to be on the tables. So effective and balanced programs should include all schedules of controlled drugs and non-scheduled drugs of abuse. It should be administered through a healthcare agency, not a law enforcement agency. About half of the programs that are in existence are administered through a healthcare agency like a Department of Public Health or a Board of Pharmacy. The other half are in law enforcement agencies like a Department of Justice. Law enforcement access should be limited. There should be multidisciplinary involvement to ensure that there's no interference with legitimate medical practice. And certainly patient privacy needs to be protected. A PMP implementation program should include educational programs for health professionals for pain management practices, recognition of signs of abuse, and resources to treat early addiction. The experience of the other PMPs that I referenced earlier, Idaho and Ohio, show that overwhelmingly the users of their prescription monitoring programs are providers. Law enforcement access is a small percentage. So the history of the prescription monitoring program effort in Montana goes back to the 2007 legislature, where Senate Bill 326 was introduced into the Senate, which would have provided for the implementation of a prescription monitoring program in Montana. That bill was amended in the Senate. Health and Human Services Committee, with the help of some interested parties. The ACLU was, I think, helpful in making it a stronger piece of legislation that was eventually passed by the Montana Senate. But then the legislation was tabled in the House Judiciary Committee and never got out of there. Ultimately, I think the reason that it failed was just stakeholders were not well informed. There is federal money available to help fund prescription monitoring programs. It's through the Harold Rogers Prescription Monitoring Implementation Grant Project. And we were awarded a grant in Montana in 2007, but were unable to accept those funds because they were contingent upon the passing of our enabling legislation. We were able to keep a small portion of that for planning for our next effort. And to that end, stakeholders began meeting in January of this year. And that group has been working very diligently to craft a prescription monitoring program ladder that will follow those guiding principles to provide an effective and balanced program for Montana. So to that end, we propose to not only collect data on scheduled drugs and drugs of abuse, but all prescription drugs. To maintain or improve patient access for care, we think that informed prescribers will provide better care. And Dr. Fishman shared some data about the states with the fewest, lowest abuse of OxyContin, also have the lowest number of prescriptions of OxyContin, and also have the lowest number of abuse. In Ohio, they are working to get some clinical benefits, or demonstrate some clinical benefits of prescription monitoring programs. They are working on a study to compare a group of ER physicians that utilize the information in the prescription monitoring program with a group that do not, and evaluate how those physicians provide care to their patients with the knowledge provided in the database. But certainly one of the goals for the PMP in Montana is to deter drug abuse and diversion. The program is proposed to be administered through the Board of Pharmacy. Ron Klein, the Executive Director of the Board of Pharmacy, is here today if you want to wave Ron. And I'm sure he'd be happy to take questions, and I've put his contact information up on, I'll have his contact information up later if you'd like more information from Ron. The plan for the Montana PMP will be to be an electronic database that provides timely data. So the data the goal is to have it be just a week old. There'll be 24/7 access for providers only. Again, data on prescription drugs, non-scheduled drugs of abuse, and controlled drugs is proposed to be collected. Access to the Montana PMP will be for providers and pharmacists for the purposes of providing medical care. Patients will be able to request their own information. Healthcare licensing boards as part of an investigation of a complaint. Law enforcement with an investigative subpoena or search warrant. Medicaid for the purpose of investigating fraud or abuse. Then the Montana PMP group has been working closely with HealthShare of Montana, which is a group of stakeholders who are working on implementing a continuity of care record, and we have some, I guess, mutual goals, and so they have been at the table with the Montana PMP looking to implement that prescription type of information in with a continuity of care record. Prescription monitoring programs in other states are trying to share information, and in Montana we say we'll share as long as the PMP in the other state provides the same protections to our citizens as our own PMP does. And we have heard concerns about privacy and security. The information in the prescription monitoring program is protected health information. It's prescription fill data, and it is covered by HIPAA. But HIPAA does allow disclosures that are required by law for the purpose of treatment, for public health surveillance, and for law enforcement investigations. So the information in the PMP is currently the data that all of these people can already receive through HIPAA. The extra precautions for the PMP that in Montana will limit access to users to users that are going to must be credentialed, and then they must specify the purpose for which they're using the data. The data isn't public record. It can't be used as part of civil types of cases. All requests and access to the information are recorded, and the data is destroyed after 3 years. Addressing security. This isn't just the internet type of program. It's a separate network with separate servers. Again, access is granted, and access must be credentialed. So we intend to apply for a Harold Rogers grant again for our 2009 effort. That grant program also allows for funds to be paid for enhancement grants. In Ohio, their prescription monitoring program was implemented in 2005, and so far they've sustained their program just on the Harold Rogers grant types of funds. Dr. Fishman mentioned NASPR, and at some point, those of us in the PMP interested parties think that they may be taking the money away from the Harold Rogers grant and funneling that to NASPR. So we're hoping that we can accomplish our goals sooner rather than later, so we know that those funds will be available. The goal would be then to sustain the prescription monitoring program with a licensing fee surcharge if and when that should become necessary. And the fiscal note that was attached to the 2007 legislation was about $365,000. So where we are is currently the Board of Pharmacy has submitted a version of the prescription monitoring program to the governor. The Board of Pharmacy is under the Department of Labor and Industry, and the Department of Labor and Industry has included the prescription monitoring program as part of their housekeeping bill. Thus, that requires approval of the governor's office because they are under the administrative branch. We have been meeting, and the Board of Pharmacy has been at the table the entire time and is totally supportive of this PMP coalition. We have loosely called ourselves. We are sponsoring our own version of PMP legislation, not knowing what's going to happen with what the governor is going to decide. And in the PMP coalition's version of the prescription monitoring bill, we included all prescription drugs. And that bill draft request was made last week. So stakeholders who've been at our table, you can read the list, and we're happy to have more any interested parties. I guess I would encourage you, whether you're very supportive, to get involved, and hopefully we'll have opportunities again to network so that we can gain support. Also, if you're not supportive, which obviously I hope you are, but I would also encourage you to voice your opinion. So with that, I thank you for your attention, and I'll answer questions at the question time.
Thank you very much. I know that Dr. Fishman's time is limited, and he will be rounding up this distinguished and diverse panel today. So the floor is yours now.
Well, thank you, and I'm not going to take up much more of your time. I think I exhausted my allotment already. This is quite an extraordinary group, and I just want to say that this is really a rare opportunity to have this diversity of people up on a panel. I think this group has given you a rare opportunity that we only hope for in this business, because the problem that we face is one of passion from all sides, but multiple problems. There's no way to argue against the fact that we have a severe prescription drug abuse problem in America. There's no argument against the fact that we have a problem of undertreated pain in America. And it's very easy for these issues to collide and undermine each other, and it's quite manageable that the solutions can be brought to the table that don't undermine each other. It requires us all being at the table respectfully and understanding that we all have roles. Law enforcement is charged with our public safety, and I've got to tell you that I'm very grateful that there are people like Mark out there. If my child has somebody giving them OxyContin in a school parking lot, etc., and this is happening alarmingly. We need them. And we also need doctors out there who are willing to compassionately and effectively and safely treat pain. And I know Mark may have relatives, and DEA person who was here who unfortunately had to leave. We'll have loved ones at some point who are in pain, and they're going to want appropriate care for their people. I truly believe that we all want the same thing. There are bad clinicians out there, and there are bad law enforcement agents out there, but by and large, my experience has been that the parties involved with this battle that we're all involved with are well-intentioned, and we can work together and find solutions. And nowhere is that clearer than in the PMP area, where it's become crystal clear that we need PMPs. Good PMPs can be an enormous tool to patients, can help the legitimate patient get appropriate care, and can help us feel comfortable as clinicians that we have a little bit of traction with the doctor, shopper, or the abuser. They're not perfect, but they can be well crafted so that they're not a problem. A problem PMP is of no value to patients, clinicians, or law enforcement, as we saw in California with our paper-based triplicate program. So while I can't tell you that the program in Montana is going to be perfect and will succeed, I can tell you that from everything I've heard, this is an incredibly thoughtful program that is making every effort it can to develop the program so it has as many of the benefits and as little of the risk or the detriments as it can have. So I applaud you, and I applaud those who are putting this program together. And I look forward to the results, because it's just critically important that we make these programs so that they are clinician tools, they're patient advocacy tools, and they're not mousetraps. And I can't say that more intently. So I don't have much more to say other than I think that we all have to bring some degree of passion, but also tolerance to this debate if we're going to succeed on both sides. One side succeeding at the expense of the other is going to be a full loss. And with that, I thank you very much for having me today.
We have time for questions, Kay?
We do. We actually have 45 minutes.
Oh, wonderful.
Scott has to leave at noon, so
Okay.
that's 15 minutes. And I just want to say, tell you, I know that you're going to want to run out of here as soon as these guys are done, or as soon as you eat your lunch, but I really hope that you will stay and help us figure out what Montana needs to do next. So please stay.
Thanks. Catherine?
Thank you, everybody. I'm so impressed by everybody who's been here. It's just been fabulous. And Starla, I know you've been working incredibly hard on the PMP program, and you and I talked a little bit, I think it was probably 2 years ago, about all this, but I have a couple of questions for you that I'm concerned about, and I'm glad we're having this discussion here. First of all, when I looked at the stakeholders, the Montana Medical Association, they weren't there. I did not see them on the stakeholder list.
Okay.
Oh, you did add them? Okay, great, because it wasn't in the, so I wanted to just make sure that physicians were really intricately, whatever that word is, involved in the process. The second thing that I'm concerned about in terms of the prescription monitoring program is we as primary care providers get a huge amount of paper that comes across our desk. And one of the more annoying ones, actually, it comes from the insurance companies, Medicare, wherever they are, saying, did you know that this patient is taking these 10 drugs and they interact this way, and don't you want to do something about this? In our electronic medical records, they also have a notice where you have to tick off if you prescribe a certain medication, you acknowledge all these interactions. A lot of them aren't really useful. So I don't want us to just have another piece of paper or another electronic thing that's going to come across our desk that we're going to basically say, I acknowledge this and go away. I want it to be meaningful. Then my third concern about the prescription monitoring program is the issue of resources. And in Missoula, there's just wonderful pain resources, just great resources for patients who have persistent pain. We just don't have that in Bozeman. We don't have it, I think we've heard from other places around the state, but we really don't have those resources. And one of my concerns about these programs is what do we do about also then creating resources where we can have people, send people to. And so those are my concerns about it.
I know Dr. Fishman has a question too, and I want you to be able to respond to her comments if you have any.
Well, I appreciate Dr. Borgenek's comments, and she's challenged myself personally and the prescription monitoring program for the good through the journey, and brought up some very important points, and I think has made the process a better process, and hopefully we'll have a better program. MMA is involved, and I'll be presenting next week at their meeting. Your second comment or question about
More paperwork, emails,
right,
that kind of
that the PMP is something that you'll have to go to. It's not going to come to you. If you're interested in using it, and you'll not be bound by law to use it, but if you are interested in using it, you'll go get it, and it's just information. It is not anything that requires you to act upon. That's your decision. And your final comment about resources is one of the reasons why I think it's really important that we're talking at the table. Again, the PMP doesn't have the answer also, but if it can be a tool or help get groups together or included as part of educational processes, I think that's just one more way to get the word out.
I have two quick questions. One is for Mark. Mark, the question came up during my talk about a patient that I had last week who I got a call from the pharmacist with an anonymous tip that the patient was diverting their drugs. As a prescribing physician in Montana, what advice would you give in terms of actions at that point? Simply an anonymous tip, you don't know who it is, and you have no collateral or correlating data.
Is this on? Yeah. Is it? No, loud. I'll just talk loud. Where's the guy that asked that question so I can look at him? Oh, I'm looking around at these two microphones going.
I'm hiding.
Okay, I got you. I think the ACLU guy unplugged me here. I mean that in a good way. It's a little known trick that we use.
Who says law enforcement doesn't have a sense of humor?
Yeah, there's a lot of people say, who says he's in law enforcement? The question basically then was, you've got information that a patient is...
Anonymous, the pharmacist says they got an anonymous tip phone call, no other information relayed to the doctor that the patient's diverting the drugs that I'm prescribing. What do I do next?
I mean, I guess off the cuff, I would suggest that you prescribers maybe reevaluate and try to determine if that is in fact happening. I don't know that I would, at that point, try to encourage you to contact law enforcement. I mean, it's probably way premature for that. I certainly wouldn't let the phone ring if you called me, but I mean, I think you should probably, my advice would be to probably try to handle that internally, professionally, as you could do.
So you don't see a clear legal, reason that has to be reported to law enforcement immediately?
Not on the information you've given me, I don't.
And my second question is for Starla. Will you guys collect, one of the fears about PMPs is that they're ultimately going to be used against doctors who don't use them. That, if the PMP's there and you don't use it, therefore you're going to be shown to be negligent because the data was available and you didn't use it. So there are lots of ways to, pretzel this and feel twisted by it. I would suspect you're not going to collect that data, but I wanted to ask you, will you have data as to who uses it, and will that data be available to anybody?
We will have data on who are users and who are accessing the system, but the legislation clearly says that physicians are not required to use the data, nor are pharmacists, and also that if you do use the data to make decisions, that you are not liable. So you're not liable either way.
So if law enforcement brings a case against me and says that I'm a bad doctor because I didn't use the database, will they actually have access to know that?
No.
That's the question. So this has been a real concern of physicians about PMPs, and I think most thoughtful PMPs are just taking that action so that the data won't be used against us.
This gentleman over here has been waiting a long time, very patiently.
Dr. Blank, you made reference to the Partnership for Drug-Free America. If I remember correctly, that organization, or whatever they are, has a great deal of money comes from the alcohol industry. Would you please comment on that? The second thing for you, Dr. Blank, is would you please explain what Legend drugs are? You mentioned that on page 9 of your handout. Thank you.
Sure. Sir, I'm sorry, I was talking with Dr. Fishman, so I missed the first part of your question.
My understanding is that the Partnership for Drug-Free America is primarily financed by the alcohol industry. And if that's correct or not, would you please comment on that and what your thoughts are regarding that?
I can't comment on that.
Anybody know? Partnership for Drug-Free America, primarily financed by the alcohol industry? Yes, no? Nobody knows?
I do have a copy of the survey that I referenced with me in my personal item, so I can follow up with you. I think it has the sponsoring organization.
So, Legend drugs.
And Legend drugs means prescription drugs. Requires a prescription.
You were next.
Oh, I have a question about providers. Can there be a case, or has there ever been a case of a provider being accused of entrapment by having a person that comes back repeatedly and to the point of solving injury? I had a patient that was actually beating herself and burning the doors and pulling her own teeth out so she could get more payments. And at what point do I write a prescription for one last prescription for this person, have the police waiting outside the door for her to pick her up for her own safety and her children's safety? And can that backfire on the provider? Please tell me how to report it.
You're all looking at me like this is... I'm not sure I'm the one to answer that. I mean, I would assume that's a call you would have to make. I mean, are you looking from a legal perspective, or?
Yeah, I am. I mean, it's my duty to protect her and her teenage children, I feel. When somebody's got a problem bad enough, they're going to pull their own teeth out. On the other hand, my hope is that she'll go to jail and get put into a drug treatment program of some sort. Her kids will be looked after by family services. But what if, she comes back 5 years from now and says, that really tortured me how you treated me, and I went to jail and I lost my job, and my kids don't trust me, and I'm going to sue you for what you did. You tricked me. You gave me a prescription, but you called the police and had them waiting for me. So, has that ever happened to anybody? Can it happen?
No, I can't speak.
I mean, I have no desire to go to court or something like that.
I can't speak for DEA, but in my experience in this state, I can't recall that happening in that scenario. And there have been scenarios that seemed more obvious to law enforcement that the doctor should be looked at, that we haven't gone there. I mean, I'm not saying it has not happened, but to my knowledge, in my 20 years of law enforcement here, I can't recall that that's happened.
Have any of the providers in the room had anything similar to that? Or how do you deal with it? Any comments? And this is a really important issue to us in the trenches. It really, really is. How do you deal with it? All the other dogs sometimes kick them out and say, they'll come back. And then they go to either the emergency room or urgent care center because you don't turn them down. So you end up with them all. And, we have the luxury of firing patients. So what happens? They go in our town, they come to Missoula, okay? And Salem, Idaho, they come to Hamilton, Hamilton comes to Missoula. Where Missoulians go eventually, I don't know. Probably speaking others. As I say, there's no end of supply. The parking lots in the schools. I had kids 15 years ago or more, 20 years ago, tell me they could buy any drug they wanted to at their middle school here in Missoula. That was 20 years ago. I said anything, and they said anything. So there's no lack of supply, but how do we assist law enforcement, and how do we assist our patients without getting into legal difficulties and accusations and stuff?
Did you have a comment?
Apparently there's no answer.
I have worked over the last 20 years at getting more comfortable talking with addicts at their level and being on their level. And I think the only problem, I don't know of a case where somebody has come back and alleged that they were harmed because of saying no. My only problem with the scenario that I know that there are cases in California, we heard about one where undertreatment was legally punished. But my only problem with the scenario you painted was that you gave the prescription and had the police waiting outside. And I think that's sort of playing the hypocrisy against the patient. And if you're really uncomfortable in a situation, what's wrong with saying, no, not now, I have something better, I need more information. And I know professional patients are expert at showing up at the right time and in the right place when your chart has been pulled and is elsewhere in the system. We all know those games. And just recognize it is a game for them and join in and engage them in conversation. Like I'm willing to give you a day's, if you don't have the information you need at the time to make the right decision, there's nothing wrong with providing a day's worth and asking them to come back tomorrow when you will have the information you need. And
all I have to do, I did call the local pharmacies and I found that she obtained something like 1,800 pain pills I could track within a 5-month period. And that's not obvious.
I would, something like, I'm really concerned about this information, and it is just information, and before I prescribe further, we need to look at some options, I guess. Just voice your concerns. They're very valid.
Okay, we have a lineup over here. Go ahead, sir.
I must admit I'm a little skeptical about the PMPs. I think the potential for abuse of that information is inherent in order to indict patients and physicians. I want to know, Ms. Blank, who we get in touch with to express those negative opinions about it.
You have multiple avenues, I guess, if you want to talk with the PMP Coalition and give your feedback. We meet on a regular basis, and we could take your contact information and have you sit at the table, and maybe we could talk about your concerns. Certainly, there's going to be legislation, or is legislation submitted so that you could contact your representatives. and let them know your concerns about the PMP and encourage them not to support something like that.
We have a follow-up.
Give you my contact information. I have a question for Mr. Wolf, too. Why doesn't physician-patient confidentiality enjoy the same immunity to subpoena that lawyer-client confidentiality does?
It's because
And-
judges make the decisions, not doctors.
Well, that's not right.
I'm just kidding. Well, we just recently litigated a case about asserting, well, I'm going to use the that works, asserting physician-patient confidentiality, where the federal government subpoenaed the medical records for 17 patients in Oregon. And we moved to quash that subpoena, and I'll say, I mean, I didn't do that lightly. I think getting a subpoena quashed is terribly difficult. But the court agreed with us and held that for certain types of information at least, the importance of that confidential, trusting relationship overrides any need to get that information. So the court didn't go all the way and say that there is a per se privilege between physician and patient, but went a long way toward recognizing that that confidentiality is important and agreed that it should at least look at that on a case-by-case basis. So I agree with you that there should be such a confidential relationship. We've asserted that, and a court has gone most of the way with us.
What, and as far as HIPAA is concerned, with those allowances of law enforcement, physicians, to gain access to PMP information, doesn't that render HIPAA kind of toothless?
HIPAA, I'm not a HIPAA expert, and there are people, God bless them, who are. There are drawbacks and benefits to HIPAA, and one of the criticisms of it is the one you just said. And so I don't really have more of an answer for that particular question other than to ask a question myself and to say, why are we granting law enforcement officers any access to this database? And if we're going to grant them some access, let's say pursuant to a search warrant, why would we do it pursuant to something that has a lower standard such as an investigatory subpoena?
Thanks.
It's a balanced approach. The law enforcement is at the table as well, and it's of course been a hot debate amongst our work groups. How much law enforcement access should there be? The 2007 legislation, when it was first introduced, said merely as part of an active investigation. It was amended then to say with a search warrant. We at the time didn't have a Mark Long resource at our table and somewhat didn't understand the restrictions or the openness that were put in the legislation. With Mark's input, we think we've made an informed decision for a balanced approach that, and Mark admits, and I'm sorry, Mark, I'm speaking for you, but that you don't want to put as part of it active investigation. That's too broad, that's too open, that's too loose. But that a search warrant is, as he said, then the PMP really is of no additional value because they can get that information already as part of a search warrant. Montana is unique, Mark tells me, in that we have this middle layer called an investigative subpoena, where you do have to go in front, an attorney does have to go in front of a judge to get a subpoena, but the weight of the evidence, and present evidence, but the weight of the evidence is less than a search warrant.
Yes, sir.
Hi there. I guess, Adam, so are you totally against PMPs? Is that here?
I guess it depends what one considers to be a PMP. If there is information gathering that looks like a survey, keeps everybody totally anonymous, and does not grant access to law enforcement officers, and perhaps where you have the ability to not answer the survey question, that is, you are not required to divulge your medical privacy, then yeah, I'm perfectly fine with that. And that's the way we collect information about a lot of our medical information, right? The federal government does that with surveys all the time.
I appreciate you sharing, I really do. But I almost feel like you're protecting the drug addict the drug seeker, and there's liberty and justice for them under your opinion. But I don't think you see the effect on the families and the children that live with these people. So living in Montana, if there's a drug seeker that I see in a small town, and then later the same day drives 100 miles south to Great Falls and is looking for the same medication, it would be nice just to be able to type on the computer and say, listen, you just got 100 hydrocodone and peptidine. Now you're in Great Falls. I just think the children or the families that live with these, their liberties and justice is more important. You know, the adults have a choice. The drug seeker, and I think you're protecting them versus thinking about the people that are affected by this.
Well, that's a fair point, and I appreciate the conversation here. I will never deny that certain drugs have a harmful effect on some people. I don't think all controlled substances do, but I think certain drugs certainly do. And I'm not denying the harm that can befall some individuals or some communities on that basis. And while I'm saying that certain drugs can be bad, certain responses to drugs can be even worse.
Well, I appreciate everybody sharing.
Yes, sir, go ahead. I think you were there before these gentlemen.
Just another question for Adam. Adam, my name is Steve Bullock. I'm actually a candidate for Attorney General. I appreciated you saying that we need to have our strategies based on reality. And of the 29 states that Starla mentioned that already has prescription monitoring programs, where are those dragnet searches of criminality occurring? And you also raised the concern that people are hacking into these programs. Where is that occurring? Because the state of Montana, creates its own program. It'd be helpful then if we had those strategies that are based on reality as opposed to rhetoric.
Absolutely, I agree with that, and I would be happy to join that conversation with you guys afterward to talk about this, to talk about the criminal investigations that have been furthered, I wouldn't say exclusively, but in large part due to searches on these databases, as well as to talk about confidentiality breaches that have occurred with them. I believe that the database that has been proposed here is not as protective of civil rights as it should be. And at the same time, I recognize that it's better than where it was when it was originally introduced. And if we realize that if there is a reality that there's going to be a database here, it's a reality that I don't agree with, but if there is that reality, then I think we should all work together to make sure that it's as good as it can be.
But so can you say that the reality is stay away from the state of Arizona because they have regular and routine dragnet searches of criminality? Or is there specific things like that you can point to?
I can point to specific searches that have been conducted pursuant to these databases, yes. I wouldn't advise you stay away from any particular state.
Question or comment over here.
My name is Wade King. I'm a nurse practitioner at Northern Rockies Regional Pain Center of Billings, and being close to Wyoming, we have a large population that enables to utilize their program in Wyoming. And I can guarantee you that it has allowed us to prevent the burst of medications. It has allowed us to cooperate with law enforcement in the state of Wyoming to take criminals, find criminals, prosecute criminals, and protect the people. And from my perspective, after using that program, this will be an excellent program, actually better than theirs. And failure to support such a program, at least from my point of view, is just continuing to support the virtue of medications. Thanks.
You're next, sir, I believe.
Thank you. I'm Vic Davis. I'm a family practitioner in a rural community about 40 miles north of here in St. Ignatius. Just had a comment. I do some pain providing, pain medication prescribing and pain programs, much like Dr. Sloboda does, in the scope of general family practice. In my contracts with my patients, if they get, before they get on my opiate program, I specifically tell them that they cannot get prescriptions for opiates from anybody but me. And or other controlled substances. So I'm one person that gets to write to them, and if I find out that they are, they immediately lose that privilege, and they can seek their care elsewhere. I don't fire them. I tell them lots of other things we can do for pain, and sometimes we are. Usually I've instituted some kind of searches for that. It's been my experience that the patient who is truly in pain and needs the pain medications won't jeopardize their access by trying to fraudulently obtain multiple prescriptions elsewhere. And I found it to be an excellent tool of just eliminating the drug-seeking patient from the practice without compromising other legitimate users. And I see to that end, I think that the registry program that's been proposed is a good way to further that end. And I guess the other question I would have for participants is, and maybe somebody else can enlighten me about this, to my knowledge, it's not illegal to fraudulently obtain prescription opiate or other controlled substances from a physician by essentially lying about it. And I've often wondered if we had legislation in the state that made it a crime to do that. And believe me, the addicts know that they're engaging in dishonest behavior. It may not be codified as illegal at this point, but if you make it codified, then you could certainly have a mechanism by which the registry, if they became aware, if the registry triggered such behavior, they would then perhaps have a mechanism to alert law enforcement authorities that a crime had been perpetrated. And I'd just like to get other panelists or anybody else's comments about that. And thanks very much for everybody coming. It's been a great conference. It's really helped me in the scope of my practice.
Any reaction from the panel?
If there's no direction from the panel, I did go to the trouble getting a copy of the state law, and it is totally against the law to obtain any narcotics under false pretenses. That could be an early refill, it could be saying you haven't seen anything else, it could be any of those things, and it is against the law, and that's why I call the law. So, but I did get a copy of the law, it's in my file, and every once in a while I can read it, and I saw people who I hate to do what I think they need to do. It is the law. And I don't know, again, that's another question, what's the penalty if I don't report somebody and I know it's the law, I can report them if they are going to do federal lines.
We can move over now.
Hi, thank you again as a patient perspective. I haven't heard anything in regard to the PMT about making sure that the patient is not vulnerable to safety issues like addicts or people who want to get some drugs for a little lesser cost to come into my home or come and break into my car or, chase me down the street when I leave the pain center. So I'd be really interested in making sure my name isn't attached somehow to these things.
Any reaction?
Well, the prescription monitoring program would be patient-specific and have patients' names attached when the information is made available to your provider as part of care. No patient information would ever be released as part of aggregate. Like I gave statistics up there about numbers of prescriptions and who uses the PMP, that sort of thing. There would never be patient information with that. But when your doctor logs into the PMP to look at your prescriptions, your name will be, they'll access you by your name, and that's how they will see your prescriptions. It would only be your doctor, just like it is with any other medical record. Only the people who are taking care of you have the right to access your record. And they need to state that or certify or justify that, why they are accessing your record as part of your care.
There is no public access as such. Question, I believe, from the psychiatrist.
Correct. What I have to say is, there's a question wrapped in here, but there's also primarily a comment. I don't think any of us in here who hold a DEA number and prescribe controlled substances do so with wild abandon and don't do so with a great deal of caution. And I might add, at times, dread and fear of being unduly or unnecessarily scrutinized by the DEA. What disturbs me is that our representative from the DEA was not here yesterday to hear a great deal of this content that might have been quite helpful. What I know is that the DEA in this state at least is woefully under-informed regarding some of our practices, such as dispensing patient assistance program medications that are shipped to our offices. Prescription medications that come through patient assistance programs from pharmaceutical companies cannot be shipped to the patient. They must be shipped to the physician's office and dispensed therefrom. I happen to know that the DEA is not informed about this. I also know that there's very little information regarding dispensing samples from our offices and how we do that and keep track of that. There's nothing that's really a set, firm guideline on that. I think it's unfortunate that those of us here who have lots and lots of questions regarding those issues are not able to get those answers all together in one room, which would have been quite helpful because now our DEA representative is gone. So I just wanted to make that comment. I think the question that I have is with regard to the monitoring program that you're discussing, what would be the harm in having law enforcement involved in that only when there has been a decision to press charges and have access to that information once that decision has been made, but not prior to it?
There would be no harm. That is just a decision that will be borne out that was borne out by our group and may be borne out. The final decision will be up to the legislature ultimately.
Yes, sir.
My name is Dan. I'm a pharmacist at Community Medical Center. I had a comment. I wanted to answer the question of why we would want law enforcement involved or able to access the PMD. And I guess my answer to that would be it would help me when my daughters enter their teenage years if they could access some sort of, OxyContin or something like that and die of an overdose. And if there's information in that PMD that could aid in the conviction of the individual responsible for getting that to my young teenage daughter, saying, you betcha, I would definitely want law enforcement to be able to access that. My question is maybe in regards to the PMD, where they're wanting to utilize all prescription drugs that has some pretty huge implications as far as within the hospital being able to access that for medical reconciliation, meeting Jacobson is on med reconciliation, which all hospitals are having problems doing right now. I was just wondering if you had any support from local hospitals in Montana to try and utilize that for the med reconciliation portion of Jacob.
The answer is yes. The stakeholders that have been at the table around collecting information on all prescription drugs, that's one of the reasons that they're very supportive, and that's one of the reasons that we're at least trying in our legislative effort to make that possible. That's a very powerful tool for those of us, all of us really, but in the hospital, especially those transitions from care where many times we can't get that information easily. It's a very, very powerful tool and really exciting. And it really would be beneficial to all people in Montana to be able for healthcare providers to have that information.
Let me also just respond to the thing you said about your daughter. And I'm not trying to poo-poo those concerns at all, right? But let's just say that law enforcement were able to access people's records through the database through a regular search warrant. And in the case that you just said, they probably would. Why are we lowering the bar? Why are we changing the rules? Why are we lowering the standard to give law enforcement even more power than it already has? And that was really the heart of my question before, because I think the search warrant thing would answer your question.
Two-part questions, Dr. Brent. Have you actively involved the ACLU in designing the PMP? If not, why not? And the second question, does the ACLU monitor various programs like this throughout the United States and make comments?
I can't, the first question is yes, we have actively involved the ACLU. They are members and invited, and they get our emails. They have a draft of our pending legislation. They are valued members of our team. They have not been to every meeting that we've had recently, but they have been invited and they have been informed. I can't answer your other question.
Sure. The question is whether the ACLU is actively involved in these sorts of things around the country. Is that correct? Yeah. Yeah. And you know, the way the ACLU works is that there's one national office and then state affiliates around the country. And so the guy right behind you is the executive director of the ACLU of Montana. I'll say from my perspective, and then Scott can answer as well. My focus is on drug policy and constitutional law around the country. And it's an honor and a privilege to be able to work on that around the country. And so when Scott or people at the state level call me up, absolutely, I do. And we try to stay on top of things even when we're not called. But the best way we do it is through the ACLU of Montana, which in my opinion is doing great work to safeguard the civil liberties of people in the state.
Yes, sir.
And if I may, Scott Crichton, I've worked for the ACLU in Helena as the state executive director. And Starla, thank you. We have been invited, we have been at the table. We were not when the legislation was first introduced in 2007 and spoke up in the Senate Judiciary hearing, at which time Senator Weinberg, chair of the committee, said, well, why don't you work collaboratively with the sponsors of this bill to improve it so that we can protect the privacy of everyone? Because it was clear that as introduced, people from both sides of the aisle were concerned about the possibilities of privacy violations or unwarranted intrusions into people's private lives. And we did that, and Starla was very cooperative in accepting our suggested amendments to the law. And so the law, as it made it to the House, was much improved and included the search warrant level requisite to get law enforcement's access. And I'll have to say, even beyond that, Trudy Schmidt, the sponsor of the bill, called me then after the session and invited me to go to a national conference on these databases sponsored by the DEA and other groups to try to make sure that our concerns could be addressed. And I went to that with some, wanted to make sure that I wasn't going to be bought off. But I thought, you know, definitely could be better informed by doing that. And it was enlightening. And Mark was there, and new head of the pharmacies was there, and it was a good team from Montana, people from the Board of Crime Control. But I have to say that what came out of it for me was a couple of things. The notion that this is something that is springing up from the grassroots is really a myth. I mean, there is a national agenda to create databases in every state. And the discussion as we first had it was as a law enforcement, as a public health tool for Montana, but it became clear that these things really are going to be interactive state by state, and you can understand why they would want them, why some people would want them to be. But it's really a national network, a national database that is being created, and there is resistance in states. Montana killed it in the House, which was not controlled by the Democrats. It was conservative Republicans that said, wait, another state database is a concern. And so the other thing that got me, I was just coming home on the airplane and reading this new report about fusion centers, which most of you probably have heard nothing about, which are another effort that was resisted as a federal effort to have a large database to collect information on everybody after 9/11 that got shot down immediately. The backdoor effort is to create state fusion centers all around the country that are mergers of military, federal, state, and local law enforcement to be able to go through databases, to be able to preemptively discover potential criminal enterprises. And the PMPs are part of those databases. And we don't have clarity. Mark understands them better than I do because the Department of Justice is at the table in that database, in that fusion center at Fort Harrison. But there's not any clarity about the accountability of those fusion centers and the citizen oversight of their gathering of data. And there is no real clarity about, in fact, some states are asserting that state rights have no role at all, that this is a federal enterprise and your right to know under state law does not apply. So I want to say to the people that have been saying, it looks like we're trying to stand up and defend the rights of criminal enterprises. We're trying to stand up and defend the privacy of all of us. And I hope that that's not lost in this discussion. Thanks.
Thank you. We have time for a couple more questions, and there are two people.
Okay.
Good timing.
I'm Lois Fitzpatrick. Those of you here last night know that I'm a patient, long-term pain patient. I have been on pain medications nonstop since, 1986. And as a patient, I am very concerned about this registry. I do not like it. I understand where the physicians, where it's helpful for the physicians. I see many different doctors, but I'm also very honest about what I take and who prescribes it. In fact, just about a month ago, one of my doctors, a pulmonologist, offered to get me some cough medicine with codeine. And I said to him, no, my family care doctor gives that to me. I'm not going for another one. So as a patient, I am very concerned about this. Also, if you heard last night, I have met people who were not diagnosed for 10, 15, 20, 25 years. By the time they finally get diagnosed, there's a great distrust, of some medical people because they were told they were crazy. Now you take that kind of scenario and you put a patient that needs pain medication and they understand that all of that is going to go into this database that law enforcement can touch and that others can look at that are probably not going to be medical people that are involved in their case. They're not going to go. This is the Montana Pain Initiative Conference. We've heard a lot about abuse. I learned a lot about abuse today. I'm on a college campus. To be honest with you, I don't see that much abuse. And that would be a prime age that there would be abuse. But remember the patient like me. Remember the other patients. Are we going to throw everyone out because of a few? And in my mind, it's a few. And when you have pain, when you're a patient, when you don't know the medical jargon, when you don't know, when you're scared and you think you're dying because you can hardly take a breath, you're going to stop those patients from coming in and getting medical help. Now, my one question is, why are all prescriptions going to be included and not just pain if we're concerned about abusers?
The thought is that if we're really concerned about patient safety, if it's a patient care tool, then really, why do we just need scheduled drugs? We need all drugs to take care of patients.
I can understand that, but I'll tell you, my pulmonologist about 2 weeks or about a couple months ago gave me an old drug that he told me was no longer in favor. It worked. Stella, I didn't hear in your talk that you talked about the opt-out clause.
I didn't.
Thank you.
Yes.
Do you want me to mention it, Kate? Sure. I assumed that it would come up, and I guess it did one way or the other. As we have crafted in our draft legislation, that if we collect information on all prescription drugs, that individuals would have the ability to opt out of having, excluding the controlled substances and substances of abuse. Individuals could opt out to have their other prescription information shared, either in its entirety or with selected drug classes, for example, antiretrovirals or medications to treat mental illness.
So this is in the proposed legislation?
This is all proposed,
right.
Correct.
And the very last question and comment.
I just want to welcome actually law enforcement. And I think there needs to be more cooperation and less intimidation.
I can tell you I have received intimidating letters in my practice when I was in Oregon from law enforcement over rules and legislation. What I want to ask is, I'm asking for your help. And I want to bring up two scenarios. One, in my practice, I had a patient forge a prescription. And I had all the evidence of that in my office. And I contacted law enforcement, and they did nothing. They didn't even send a law officer over to collect the evidence. We were advised that they weren't going to do anything. So we have that in the patient's record. Law enforcement did nothing. The other way that I find out in my practice about criminals activity, we have somebody in my office who reads the newspaper, and we see who on public record was arrested. And we call law enforcement on these patients. And I say, I have Mr. or Mrs. Jones in my office. I understand from the public record that there was an arrest for drug trafficking. And I ask for assistance in law enforcement in documenting that in the patient's record so that I can track what's going on. And I get stonewalled. And I'm sure you guys get stonewalled on the medical side by the HIPAA rules. So we have to work on barriers of working together rather than intimidation.
I think, Kay, that during this panel has emerged a construct for the next conference. Clearly, there's a lot of need for continued dialogue of this sort. It's so important and so healthy. And we want to thank the panelists for persevering. Great discussion. And now, Kay, I think the floor is yours.
So, Kristen and I haven't had very much sleep over the last week. And this morning at 7 o'clock, when we were meeting again in the lobby, we looked at each other and I said, I'm not sure if caffeine would be good or bad. She said, I'm not sure either. So then we went ahead and ordered some coffee, which was good actually. But we stayed outside for a little while Scott was talking, just to kind of de-stim a little. And I looked at her and I said, I'm not sure I'm fit for company. She said, I'm not sure I am either. Because the adrenaline is like flowing out at this point. But we're gonna make it through this thing. And I know you're all tired too, because you've been working very hard this whole time. So I'm gonna tell you about the Montana Pain Initiative, and I'm gonna try to do it as articulately and as quickly as I can so that we can move on to planning. Okay, so, some of this I'm going to kind of breeze through because this whole conference is sort of like, why create an MTPI? Well, this conference is an example of why. And so, but really, and you all know that pain is undertreated or you wouldn't be here. So, and you've already heard these stats. So I'm just going to kind of cruise through things that people have already talked to you about. You don't know probably that the Pain and Symptom Management Task Force actually did a survey of community members. It was a convenience sample survey, and I'll tell you in a second where all they got the information from, but 329 people filled that out, and of them, 62% of the people said that they experienced pain. So we can't get Montana data, which is really a drag on the, how much pain is happening. There's just no way for us to collect it unless we can really hook up with the pain centers, but then that would be a select crowd. So anyway, one thing that we would like to do is try to figure out how to get some of that data. The Pain and Policy Studies Group is a national group that grades states on their pain policies, and Montana can. This is one of the reasons why we wanted to create the Montana Pain Initiative, because we keep getting a bad grade, and then also because of diversion issues. This is the group that does the grades, and Montana has continued to get a C+ from the year 2000 to the year 2007. So we're not getting worse, but we're also not getting better. And so we really want to try to fix some of that. Kristen and Dr. Borganet and I are going to be talking to the Board of Medical Examiners on September 24th to present to them what the Federation of State Medical Boards model policy is on pain management at the board level, and hopefully they will be willing to modify some of their policies. One of the policies that's problematic that continues to get us a C+ is that it says that opioids should be used as a last resort. So we're going to really work with them and hope. They haven't revised their policies since 1996, so we're hoping they'll be willing and ready to do that. If you want to see that report, you can go to our website. This is the things. This is what they grade people on. So I'm just kind of going to skip through some of this. But we feel as a PAIN initiative that it's really important to improve policy that are restrictive, but we also really need to improve practice and to communicate policies broadly so that they're understood and put into practice. And as you saw from this conference, we really are about a balanced approach, and we really do want communications from all law enforcement to ACLU. You know, we want everybody. So we're going to continue to work on keeping people together at the table, talking, so that we in Montana can do it really well. The American Cancer Society is very committed to having states get good policy grades. They are committed to pain management. They see it as not just cancer pain, but cancer or pain across the board. If it's not managed well, cancer pain is not going to be managed well either. So they are very behind the state pain initiatives, and our Great West Division is really, I mean, the American Cancer Society has funded this project from the get-go and continues to do so, as well as the sponsors for this conference and some other people that help us. But the American Cancer Society is really why the Montana Pain Initiative is capable of keeping going. So you already know a little bit of our history because you've been hearing about it. Carolyn Squires introduced this Senate resolution that made it possible they recognized the formation of the Montana Pain and Symptom Management Task Force. That was in 2005. And they were really just a fact-finding group where they were looking at what is going on in Montana around pain management and what is going on nationally. They did research to see what the national pain foundations and organizations were suggesting that should be good, what is good pain management. And they put together then, and this is about the survey, sorry. They did this survey too to help them to know what was going on in Montana. And they did public forums, and they handed out the surveys, and they handed out surveys at flu clinics and chiropractic practices. Family practitioners handed them out, and pain specialists, and then the task force members just handed them out to anybody that they could get to fill them out. So in that way, it's not like a randomly controlled design, but it did give some information about at least the people that were willing to fill it out, that a lot of them did have pain. The white paper was the result of the Montana Symptom Management Task Force, Pain and Symptom Management Task Force. Their 2 years worth of work resulted in a white paper that provided us with evaluative recommendations, organizational policy, and education. We have used that white paper a lot, and the recommendations were, first of all, to support the efforts to create a Montana Pain Initiative. So it went from a fact-finding group to a viable, self-sufficient project of the American Cancer Society. And because things are moving so great in Montana around all of this, the American Cancer Society, who was originally just the fiscal agent for the group, has really taken ownership of the Pain Initiative. And so we are a project of the American Cancer Society, so we get all the resources that the Cancer Society can provide to us, and access to it becomes a mission for everybody. So the Relay for Life people can talk about pain management, so it's really very exciting that the American Cancer Society has taken such a great role, and that's in the Great West Division. We did a 2-day planning retreat because Lance Armstrong Foundation and the Alliance of State Pain Initiatives gave us a grant that allowed us to hire a moderator, a national facilitator who came in, and we developed a mission statement, a vision statement, and a governance structure. And we were able to do that all, and then we did a 5-year strategic plan, and we were able to do that in 2 days because the white paper set it all up for us. So the 2 years of the task force really, really helped the initiative to move forward fast. Our vision statement is access to responsive, comprehensive pain care for all. Our mission statement is the Montana Pain Initiative is a grassroots interdisciplinary project of the American Cancer Society dedicated to improving the quality of life of Montanans with pain by removing the barriers to effective pain assessment and management through research, education, and advocacy. Oops, that went too fast.
So our organizational structure is that we have staff, that's basically Kristen and myself, and we have an advisory council who helps me all the time and serves on my committees when I need them, whatever I need help with, they're amazing. We have an executive committee. We just are really getting started, and this conference just really took all of our time. So we really haven't put together yet standing committees, but we did put together a work group because the work group created this conference for you today. We are going to have memberships, but we haven't quite figured out how to do that because we're a part of the American Cancer Society. We can't charge a fee for membership, but we can take donations, and we just haven't quite figured out how to get you an application form so you get on our list. But we'll get there with that, right, Kristen?
Do you have tax deduction?
We're part of. Kristen? Where are you? I'm right here. Oh. We are a nonprofit organization because we're the American Cancer Society. Is that what you're asking?
Well, yeah. I mean, if the check's made out to you, is it be nonprofit, or does it have to go to the American Cancer Society, say, designate it to the...
Yes. The checks have to be made out to the American Cancer Society, and then in the memo line, put Montana Pain Initiative.
You're making a donation, when you make a donation to work on this project, you're making a donation to the American Cancer Society. And all you have to do is put in the memo line the Montana Pain Initiative, and it will go towards this project.
Right.
But because we are a project of the American Cancer Society, it is tax deductible.
Yes. Did that answer your question?
Yes.
Good. Here's our contact information, so you have it if you want to contact us. The Advisory Council is a unifying body of informed advocates. We're trying to meet quarterly, but we haven't quite gotten there because this conference sort of took over. And the people are serving for 2 years, and right now we sort of appointed people, but when we really get structured and organized, then they will be elected by the Advisory Council will elect new members and the Executive Committee too. The Executive Committee, Randall Seacreast, who you know well now, is our chair. Jean Forsyth, I'm not sure she's still here. There she is, back in the back. She's from Billings, and she is our vice chair. And Catherine Borganet, who you also know well by now, is our medical director. And then Kristen serves as the Cancer Society liaison, and then I am the program director. When we get our standing committees going, we'll have one on public policy, one on public engagement and advocacy, one on provider practice improvement, sustainability, leadership development, and finance. And then we'll also have ad hoc committees doing things that are underneath those. The strategic planning process really moved us from recommendations and strategies to measurable outcomes. Very quickly, I'll just go through these quickly. These are in your white paper, by the way, because these are the recommendations of the white paper. To support efforts to sustain the Montana Pain Initiative, integrate pain surveillance into existing statewide health monitoring systems, support initiatives that will conduct large-scale studies of patients, healthcare providers, and pain management systems in Montana, build institutional commitments to improving pain and symptom management, modify existing and adopt new policies that could enhance pain and symptom management in Montana, require or encourage provider practice improvement education in pain management, encourage licensing boards and professional associations to regularly inform licensees and members about pain management policies and guidelines, encourage development of public education regarding effective pain management, and encourage development of public education regarding patient advocacy. So our existing projects, we just completed in March a pain improvement partnership project, which we also received funds through the Alliance of State Pain Initiatives, which were also Lance Armstrong Foundation dollars, to institutionalize in facilities better policy around and structures around pain management. So 13 facilities that participated. We were only allowed to do 20, and actually, though it's 13, several of them actually sent, because in Montana, in rural areas, long-term care facilities, home health agencies, and rural hospitals are often combined under one umbrella. So a number of the facilities that sent staff from all three of their areas. And they really committed a lot to this program. They they collected internal structural assessment data and patient pain surveys. They attended a 2-day workshop, and they created action plans. And then they went back to their organizations, and they implemented their action plans as best they could in a very short period of time, like about 4 months, with the holidays in between there. And then they recollected their data so that they could see whether they improved what they were doing. And they attended another 1-day workshop where they got a little bit of training, but mostly it was about them sharing with each other their successes and challenges in trying to change policy and structure within their organizations. And Shelley here, who spoke last night, was a part of that project. And it was an amazing project, wasn't it? We really appreciate the money from the Alliance of State Patient Initiatives, and we're hoping. We did it in Western Montana. We really want to do it in Eastern Montana. So we're hoping to figure out, well, we will figure out how to get funds to do that. We have a Lance Armstrong grant out, and I'll tell you about that in a minute, but maybe, oh, here it is right here. We wrote a Lance Armstrong Foundation grant. First, we wrote a letter of intent. Then we were invited to write a full proposal. It's the first time the American Cancer Society has been asked to write a full proposal. So the Great West Division is very excited about that. We're looking pretty good at the moment. In that, what we said we would do is 2 focus groups with survivors, one in Eastern and one in Western Montana, that would really sort of set the base for what kind of education. It had to be focused on healthcare provider education, by the way. So we wanted to find out from the survivors and it had to be focused on cancer too, actually, because it's Lance Armstrong. So what do the survivors feel like that the healthcare professionals need to know, just to kind of give us a base from the consumer's perspective. And as you all know, you're going to be receiving the Responsible Opioid Prescribing, a Physician's Guide from the Attorney General's Office and the Medical Examiner's Board. Unfortunately, RNs are not going to get that book, but if you were because you don't prescribe, but if you're interested in it, we can certainly sort of figure out how to get that to you in some way, maybe. We also want to do, like I said, we want to do the Pain Improvement Partnership Project in Eastern Montana. This is over 3 years, by the way. We want to do 2 risk management workshops to help physicians better understand how to prescribe opioids and keep risk down. And we're going to do, we said we would do video interviews on the web. Dr. Seacreast actually has a website where he streams conversations, interviews with pain management specialists. And so what we said we would do would be, he would interview a cancer patient with pain, a caregiver who's taking care of a cancer patient with pain, a pain specialist, a primary care physician who's taking care of someone with cancer who has pain, and one more and I'm blanking on it. But anyway, just kind of across the board, what are all the pieces of healthcare and the people that are involved in it regarding pain management. And then we want to pilot a mentor program for primary care physicians. So we would hook up, we said we would have 3 mentors and 12 primary care physicians who would use their mentors to help them to learn how to do better pain management. We did receive a grant from the American Cancer Society Cancer Action Network, a state pain activity grant, which basically paid my salary in order to help put this conference on. So we really owe them a great debt, because you wouldn't be sitting here without them. And then to just work on the Scott Fishman book, which we got figured out great, because we have a great board of medical examiners and we have a great attorney general. And we're going to be working on the policy changes, and that's set for September. So we're making really good progress with this grant that we got. And then, of course, you know about this because you're here. This is really what we have been focusing on since January, other than writing continual grants at the same time. We have a website, and we have a logo, which you've seen many times now. It's down there in the corner of the slide. And we are working on the prescription monitoring program. We sit on the work group. Kristen has been a very positive influence in that group. I've learned a lot from her, and I think everybody on the coalition has learned a lot from her. And I just want to thank you, Kristen, for all the work you're doing. I think she has a lot to do with what Scott Fishman told me on the way out the door. He thinks we may end up with the best prescription monitoring program in the country. So, okay, but our success does depend on you. It depends on you to come to conferences, but it also, we need help. And so there's a sign-up sheet out there on the table that if you want to join our listserv, just sign and it's not a real, you won't get like 50 million, it's not like people chat on it. So it'll be us like asking you for help or telling you what's going on or things like that. It's not real active. It may get a little bit more, but anyway, so we would like you to recruit others to join the initiative. Serve on a committee or workbook group would be great. And of course, make a donation if you want to, because we need money to keep going. We also need your input. Potential partners in your community, anybody you can think of that you think would be good to be part of the initiative, whether it's serving on the advisory committee. The advisory council actually represents the various associations and organizations in healthcare. So we really ask that those people sort of be our feed into their group, where it is like the Montana Nurses Association or something like that. One person would be the way into that. Mental health professionals, there have been some at the conference, and we don't really have any on the advisory council, so we really need to start interfacing with them in a better way. Law enforcement, like what we're trying to do here, and then cancer centers. So we really want to work together as a group to really try to improve pain management in Montana. And we really want to take a balanced approach, and we really want to keep the lines of communication open. And what you saw here today and yesterday was an example of where we're trying to head. And as Dr. Sechrest said to me down there, this discussion that happened today has only just begun. So please help us, and thank you for coming. And Kristen's going to come up here and tell you, or do you want to just me to tell them what they're supposed to do? Because are you coming up? Okay, great. Well, do you have any questions? Do you have any questions? Thank you so much for coming and making this a successful conference.
I get to be more informal, so that's nice. Thanks, Kay. You know, Kay keeps thanking me, but I tell you what, we have really found a gem in Kay Norris. She has just been an amazing force on the pain initiative, and I can't tell you how valuable her experience has been and her tenacity. If you're a speaker at this conference, you know what I'm talking about. So let's give Kay a round of applause.
I didn't do it by myself.